No, I don't. हाँ, few attendees also. Yes.
15 attendees आ गए हैं यार, वाह।
Why are you surprised, Akshay? Akshay, you must have worked with my sister, Debranjini.
Oh yes, oh,
I am the younger sister, the prodigal one.
oh my God.
Gopinath is not going to agree with me on many things. He's going to probably malign against me.
You guys are working at the same center or what?
No, I was in CMC. Now I have joined in AIMS Nagpur.
Fantastic. Both of you are hemato-oncologists, huh, ma'am?
Yes.
गजब। So आपका तो रोज ही मतलब in the evening you guys are having the tumor
Yeah, it
board,
is
huh?
like 24 hours of hematology. So sometimes when we both meet, we decide actively we won't talk, but it lasts 15 minutes. Till I
Oh.
get a text or she gets a text from someone.
Nice, nice, very nice.
And your parents must be like quite bored.
Yeah, they are bored. Like, अभी तो घर पे तो ये मत चालू हो जा, आप दोनों घर पे तो चालू मत हो, ले मम्मा रुको, and we start.
So Devranjani is there in the expert opinions. She should be here then.
I don't think so. It's her OPD today. And last I spoke to her, I tried calling her, she cut my call. That means a bad OPD is going.
Okay.
Oh.
And who else? Nakul. Can we call Shubhashri? Can you please call Nakul and Dr. Nakul and Dr. Sodamini once?
Yes, ma'am. Sodamini ma'am told me she will join me shortly.
Okay, okay.
Yes, slides we have to run from our side या फिर they will be running. Sadrupa.
We'll have to run from our side.
And slides forward कर दिए थे आपने?
हाँ, मैंने सबको forward कर दिया था.
Right. नकुल नहीं आया अभी.
Satrupa, are you coming for MHG?
No, not this one. Next,
this
I'll
one.
go in January.
The January one. I don't know how it has happened. I'm going for this one. So I thought I might meet some of you there.
Others, Akshay sir goes, Dr. Gopinath goes.
Gopi, are you coming?
Coming. I
Oh,
just this time I'm not coming. I just went in March, no, some leukemia speak program, something happened. So this time I'm not coming.
Gopi is one of the favorite of
yes,
MBL.
yes.
All-time favorite.
Agree.
I'll tell you what, Sohini is the biggest terror, I told you, all of you.
Oh, please.
Satrupa,
I'm
more
not.
than you, okay?
I'm
Huh?
not. Right? You are the biggest terror, Gopi. I'm scared of meeting you because you will start with this dialogue.
यार बिस्वा भी नहीं दिख रहा है, बिस्वजीत.
Where is he? I talked to him like 10 minutes back. I'm calling him. I'll call him. Wait for another 2-3 minutes, and then we'll start.
Okay, ma'am.
So I think, yeah, we'll go ahead. We'll start.
Okay, ma'am. I'll start.
So hello, everyone.
Biswajit has joined as an attendee. He has not joined as a panelist.
Can you make him a panelist, Subhashri, Dr. Biswajit?
Yes, ma'am. Sure.
Yeah. So, a very good evening to everyone. Today we'll be having a discussion on acute myeloid leukemia. And I thank the speakers, the moderator, and all our panelists for joining in, for sparing their time on a working day. And so I thought AML is always something very like I think we feel it's still challenging to treat in India. So we'll discuss the newer therapies, one end where the field is rapidly evolving, and at the same time we'll have insights on how we manage AML in our day-to-day practice. So we have wonderful speakers, wonderful moderator, and wonderful panelists. Thank you all so much for agreeing to be a part of this. And I think we are ready to start. So I first invite Dr. Gopinathan M. He's a consultant hemato-oncologist and BMT physician from Chennai, and he'll be speaking to us on the newer challenges in AML. Thank you, Dr. Gopi.
Thank you. Thank you, Dr. Satrupa, for that warm introduction. And can I request the officials to give me permission to share the slides? I think they should switch off the screen.
Yes, sir.
Hope my slides are visible.
Mm.
Yes,
Yeah.
sir. Visible.
Yeah. Okay, let me just put it in a PowerPoint mode. Yeah. Okay, good evening. So I agree with Dr. Satrupa that the field of AML is rapidly evolving, and I think most of us want to see, don't want to see the same toxicity, chemotherapy, more of infections, infection-related mortality, and we want to really keep the field light so that you are also comfortable and the patient is also comfortable. So the next 20 minutes, since it's only a short span, I'll be just focusing only on the recent drug advancements and how does the field of landscape is going to change in the next decade or so. So what we will cover is, in this following subheadings, we'll just cover the shifting AML landscape. These are some of the drugs which we focus for today's discussion. One is ASTX 727, that is your oral decitabine cedazuridine. Third is your menin inhibitors, quizartinib, cellular therapies, and how do we sequence this agent. So that is what we are going to cover in this agents in the next 20 minutes time. So we all know that the learned audience over here know that AML is no longer considered as a single entity. In fact, it is, it's a multiclonal disease where, you may have a different clone of mutation causing the disease, initiating the disease. You may have a different clone of the disease being at the progression. So the current focus of topic today, which is newer therapies in AML, is focused on this three particular axes. One is your DNA methylating agents, that is your hypomethylating agents. Second is your menin inhibitors. And third is something new on FLT3 signaling. So since these are more of a targeted therapy, we also have a broad spectrum therapy, like a cellular therapy, also evolving in AML. But still, though they are at much preliminary stage and not really much advanced, most of them are in experimental trials. So for a specialist audience like us, where the things are not like whether the therapy is going to work or not work, it is like how we sequence the therapy for the better patient care. So mainly why we need to have this targeted therapy, or why you need to have such newer agents in clinical practices. Obviously, we all know the problems with intensive chemotherapy. We have multiple infections, therapy-related mortality, and the CR rates, the composite remission rates, will start decreasing as the age inclines because of the higher mutational burden, as well as since with age also we kind of try to dose adjust chemotherapy, which leads to suboptimal response rate, and which leads to increased relapse rates and resistance rates. And all these are attributed to your molecular heterogeneity. So what basically we achieve from this targeted therapy, all the newer agents, the current agents that we are going to see is we want to have a selective inhibition with minimal off-target side effects, so thereby lower toxicity. And obviously, we aim at getting a good MRD clearance. So we all know that good MRD clearance is an important factor that designs a long-term, survival and disease-free interval. And many of these therapies that we are going to discuss is often used as a bridge to transplant. So you may have a difficult patient where we are finding it very difficult to get into remission. So you may use these agents for getting into remission and then bridge them to a standard consolidative strategy like an allogenic transplant. And so you can also use these treatments in combination as well. So these are the agents. So one is focused at epigenetic priming, which is your oral decitabine and cedazuridine. Second is your menin inhibitor. Third is your FLT3 signaling inhibitor, which is your quizartinib. I think all the other agents, I think all of us are used to with midostaurin, gliteratinib and all these things, all of us are used to. So what quizartinib has to do with FLT3 inhibition. And the last is our cellular therapy. Since it's just a 20-minute session, I just run through a short description on all of the trials. So the current standard of care for any patients with AML who is kind of not fit or with some kind of infection is a combination of hypomethylating agent, plus or minus you can add venetoclax depending upon the tolerance. So what this particular agent, since there is a lot of inpatient admissions, at least they have to visit, even if it is an IV decitabine, they have to at least come 5 days to your daycare, or they have to be in-house for getting this, decitabine. So what if the drug can be given oral? But the main challenge is if you give an oral decitabine, it is degraded in the gut and liver mainly by cytidine deaminase. So what this cedazuridine does is it just inhibits your cytidine deaminase, and then so that potency or the efficacy of decitabine is preserved. So you give this combination of decitabine and cedazuridine. So decitabine being the DNA methyltransferase inhibitor, that is how you get an action against AML. So how this drug is derived and how this drug is going to come into clinical practices. The trials came across in 2 phases. The first is just a simple ascertain AML study where they tried looking at the pharmacokinetics of this drug. So this was the study population was those newly diagnosed AML who are not candidates for intensive injection chemotherapy. So in this initial study, only those unfit patients with a lot of comorbidities, unable to get an intensive injection, or for that matter, standard HMA venetoclax were chosen, and the study design is nothing but a 2-period, 2-sequence, 2-treatment crossover study design, which I'll just explain. So initially, when this drug was chosen, only decitabine cedazuridine was given, and subsequently in the studies higher up, that is in the phase 2 and phase 3 studies, venetoclax was also added. So the first aim of this study, the initial studies, were mainly to look at the pharmacokinetics between IV decitabine and oral decitabine. So that was the primary endpoint. So how 5-day total area under curve exposure were equal between oral and IV formulation. So that was the primary endpoint of this initiating study, which is a certain AML study. So again, so since they had, so they had conducted the study in 2 designs. You have the sequence A, where the patient receives oral decitabine, that is in the cycle 1. If they had received cycle 1 oral decitabine, they can receive IV decitabine in cycle 2. So sequence B is they can, if at all, it's the reverse. If they get IV decitabine in cycle 1, in cycle 2, they get oral decitabine. And finally, they calculate area under curve between both the cohort of patients. So in what they proved is between IV decitabine and oral decitabine, the area under curve is almost the same, the efficacy is almost the same, and the toxicity is also almost the same. So subsequently, they went for this azacitidine 5 study, which tried combining venetoclax with the same oral decitabine combination. So once that you prove that the efficacy is same between IV and oral, toxicity is similar between IV and oral, then you add your proper regimen, which is your venetoclax. So again, this was conducted in those unfit patients with combination of decitabine and venetoclax. So it was conducted in multiple trials, phase 1, phase 2A, and phase 2B. The only difference between phase 1, 2A clubbed together is they had a pharmacokinetic sampling in the cycle 2, whereas in phase 2B, they moved this pharmacokinetic sampling to cycle 1 itself. So that is the main difference between these 2 phases. And why did they do so much of pharmacokinetic studying is they also, since both being an oral agent, that is your decitabine and venetoclax, both being an oral agent, they wanted to check exposures of each other's influences, both the drugs' influences on each other. And obviously, when the study advanced, so the main primary endpoint became your CR rate and then second is your overall toxicity rates. So this was the results of this study, which is a combination of oral decitabine, cedazuridine plus venetoclax. The CR rate is almost close to 46.5%. With you have incomplete recovery rates close to 16.8%. And the median due time to complete response was 2 months, I think, which I think most of us will agree. For anybody with HMA, we almost take nearly 2 months time to get a CR. I mean, almost 60-70%, though they get in cycle 1, to get a complete remission, you get at least 2 months to get a CR. So this was the median time to CR. And the responders remaining in CR at 6 months was 80%, and the entire follow-up of the study was 11.2. So even as per the current data accrual, so it was the follow-up was close to 15.6 months. So and again, toxicity, if you see, as with any other hypomethylating agent in venetoclax, you have a toxicity rate of close to 30%. That is grade 2, grade 3 toxicity, close to 30% of 30% of severe anemia, severe neutropenia, and febrile neutropenia, and so on, which I think most of us are easily able to manage in an outpatient, in a hospital setting, inpatient setting. So this is the other common expected complication, that you get a simple fatigue, peripheral edema, arthralgia, myalgia, and mild mucositis is noted with this regimen. So most of us with azacitidine, I don't think we know this. But grade 3-4 neutropenia and thrombocytopenia, grade 3-4 is only 25%, whereas overall cytopenia is close to 63%. And the therapy-related mortality is as low as 3% and 10%, so which is quite comparable when you do a intensive chemotherapy. So that is with this oral decitabine cedazuridine regimen. Second, we move on to menin inhibitors. Why this is important is the problem statement. So if you have, when you have a relapsed NPM1 AML, you see the median OS is as short as 6 months. When you have a relapsed KMT2A AML, again, it's most worse, which is 2.1 months. So what basically this menin inhibitor does is, so this is the biology of it. So if you have this KMT2A, and you have this menin. So menin is actually menin, NPM1, all these are binder proteins, and KMT2A is a transcription factor. So in a deregulated, in a mutated, either if you have a KMT2A mutation or if you have an NPM1 mutation, what happens is they upregulate HOXA-A9 and MEIS1, which ultimately leads to uncontrolled check-on transcription, and you get a frank leukemiogenesis, you get a frank leukemia. So what they try to do is they try to just inhibit this menin, which is just a binder protein between these, fusion protein, and this is a transcription factor. So when they try to inhibit menin, what happened is you get a downregulation of HOXA-A9 and MEIS1. So ultimately this leads to cell differentiation. So obviously when you use such kind of inhibitors which lead to cell differentiation, the toxicity that you're going to anticipate is a differentiation syndrome, which is one of the problem that is noted with this agent. Right. So what is the inhibitor that I think, that is approved for this agent? In the first, the foremost agent that was approved for this particular pathway inhibition is revumenib. I think most of us would have started hearing about this drug in our forums, and many of those would have used it also. So this is nothing but an oral selective menin inhibitor, so which kind of displaces menin from the chromatin at HOXA-A9 MEIS1 locus, so thereby you drive the differentiation. Again, the problem is the drug is at this point of time, there is no compassionate access. It's to be paid, and it is extremely priced. I think for the month cost itself comes to around 12 lakhs or something. But the thing is, again, if you use a strong CYP3 inhibitor, you can have a slightly lesser dose of 160 milligram BD. Whereas if you use without a CYP3 inhibitor, your dose is somewhere between 270 milligram twice daily. And again, the weight, according to the weight, this drug is also approved in pediatric population. So where if the weight is less than 40 kilogram, you follow more of a meter square based dosing. So initially, to start with, this was approved for relapsed refractory KMT2A rearranged ALL as well as AML. And subsequently, in 2025, the FDA also approved this use for relapsed refractory AML. So that and following this drug, multiple menin inhibitors were developed. So as I said, the initial treatment population were more of a relapsed refractory acute leukemias. And you must see this bad cohort of patients. The median line of therapies is close to 11. Median is 2, and the range is between 1 to 11, and 57 were refractory to recent line. The recent salvage chemotherapy, 19 were primary refractory, almost 50% were post-transplant relapses, and in that 7% was actually double transplants. So you can see such a badly selected cohort of population, and this what this drug did to this population is, you can see. So this was the response rate of this trial. You can see the overall response rate, that is including CR plus partial recovery, is close to 36, close to 63%, sorry. And if the CR rate is only 22%, but there are more of partial responses. The advantage is, even if you have a partial response with this drug, they are, they are bridged to allogenic transplant, right? Next. Yeah. So this was the results of the initial efficacy studies, that you have a CR rate of close to 21%. Median duration of this response was 6.4 months, and those percentage, from this cohort of patients, almost 23 went in for a consolidative allogenic transplant. And post allogenic transplant also, you have a provision to take this drug as a maintenance. Again, in NPM1, you can see that the CR with incomplete hematological recovery rate is 23%, and the median duration of follow-up is median duration of the response is 4.5 months, and the survival again in this cohort was only 4.8 months. Again, as I said, the main important toxicity concern that you need to note is your differentiation syndrome and QTC prolongation. The rest all side effects are manageable by most of us. Right. So following revumenib, you have, so as any new drug enters the clinical trials and market, so initially it will be just a monotherapy in relapsed refractory setting, as you can see here. But as the years mature, as the experience of the drug matures, you start adding it with your chemotherapy regimens. Like this drug has been trialed with 3+7, has been trialed with HMA plus venetoclax also, and now after the proving the efficacy in relapsed refractory disease, you can also see that this drug is being used in upfront setting also, newly diagnosed NPM1 and KMT2A rearranged AML also, particularly in unfit patients to see for its efficacy. Second drug in the same, with the same pathway inhibition is ziftomenib. The main difference between revumenib and ziftomenib is ziftomenib we have to dose twice. So this is the oral, this is also a menin inhibitor, but the advantage is you can dose it OD. That's a single dosing. And again, there is no requirement for CYP3A4 dosing in this approved regimen. So again, this drug is also undergoing trial, and this drug is already approved in the NPM1 AML cohort. So this was the initial trial results, particularly with the relapsed refractory NPM1 mutated AML. You can see again the CR rate is almost similar, close to 21.4%, and the median duration of response being 5 months. With of those CRs who are MRD negative are 63%. So it kind of, in the CR, you have almost 63% of this population getting MRD negative. So differentiation syndrome is something that you need to keep in mind, and QTC prolongation as well. Again, enzomenib is a slightly different pharmacokinetic profile. That is, it is more lipophilic, and it has got a shorter half-life. So that's why you need to dose this drug BD with or without CYP3A4 inhibitors. The advantage, the hypothesis is, since you have a rapid clearance, you may reduce some kind of an off-target toxicity. So that is the main difference of enzomenib from the other two agents. Right. Again, this is also the trial that start the initial phase 1, phase 2 dose escalation study of enzomenib. Again, the study cohort is relapsed refractory acute leukemia, AML, KMT2A rearranged, and NPM1 rearranged AML. And the main important thing is those other leukemias, that is your NUP98 rearranged leukemias. Most of us would have seen this report in NGS, that is your NSD NUP98 fusion, and it has got multiple partners. So this is also driven by this, all this HOXA A9 and MIS1 driven genotypes. That is particularly this NUP98 also derives its pathogenesis to this through this particular transcription factor. So they were also included in the enzomenib study, and this is the dosing. And you can see that enzomenib is also used in combination with azacitidine and venetoclax. And you can see a response rates are slightly better. It's almost close to 59.1%, and with CR rates almost as double of the initial thing which we saw, it is 47%, and the median overall survival is close to 8.5 months. Right. So this is in short a combination of, this is in short about the major differences between revumenib, ziftomenib, and enzomenib, and I think I had summarized them in the previous indication. So following all these three drugs, we have another drug that is newly developed in AML, particularly in this cohort, which is bluxeminib plus azaven, bluxeminib monotherapy. So again, they are all in much primitive trials, but showing greater response rates than your the other two other three agents. You can see that the overall rate in relapse refractory setting itself is 36.4%. And for this newly diagnosed cohort, you can see as high as 90%. So I think which is quite encouraging when we, as the drug also moves on and the combination therapy with this targeted agents also moves on, you get an increased overall response and CR rates. Right. So in short about quizartinib, I think most of us know or very well aware of this FLT3 inhibitors, which is your class 1 and class 2 inhibitor. So this is a type 2 FLT3 inhibitor, which has got a very high binding capacity and which lesser off-target side effects. So the main take-home message with this particular drug is that it's as like any other ratified trial or any other FLT3 inhibitor trial. So this was added. It was just randomized to standard chemotherapy consolidation along with quizartinib, and the other arm had just standard chemotherapy consolidation plus or minus transplant. So both the arms allowed transplant. So what is the main take-home message from this quizartinib study is, you can see here the relapse-free survival with quizartinib is much better. Quizartinib achieved much more MRD clearance. And the main, I want to just concentrate on this particular graph, that is on the right-hand side, the overall survival in patients who received maintenance with allo transplant, who received maintenance without allo transplant. So what it says is, without you doing a transplant or not, if the patient is on quizartinib during induction and consolidation and quizartinib maintenance, the response rates are almost same, right? So allo transplant didn't make any major difference, particularly when you use quizartinib and if the patient is MRD negative. So in that case, I think most of those patients who kind of deny transplants or don't want to proceed to transplant can just get away only with quizartinib. Again, as with any other FLT3 inhibitors, you see a slightly increased QTC. You have some kind of hepatotoxicity and myelosuppression, particularly when you use it with CYP3A4 inhibitors. So the last 5 minutes where we can just touch a little bit on the cellular therapies in AML. So we all know that unlike CD19 and B cell malignancies, there is no such AML surface antigen which is universally expressed on leukemic stem cells, and they are expressed on leukemic stem cells also, as well as normal hematopoietic stem cells also. So the basic risk is, if you just start ablating the leukemic stem antigen expressed on the leukemic stem cell, that is LSC, you also have some kind of off-target toxicity. You get significant myeloablation, and the counts don't recover at all. So ultimately, we'll be losing the patient to infection. And the second thing is obviously the bone marrow microenvironment, which is much immunosuppressive. So it kind of poses some difficulty for the CAR T and CAR NK cell to track, persist, and do its action as compared with your lymphoid malignancies. Because I think between ALL and AML, the main difference is in the tumor microenvironment. AML tumor microenvironment is much more immunosuppressive, where the CAR T penetrating the microsuppressive environment, the tumor immunosuppressive microenvironment, and then you kind of do its action is much more difficult. And also, it is important to know that since we see most of this MPALs and some of the acute myeloid leukemias, you have the same mutation in the myeloid stem cell also, you have it in the T cell also. So that is why you're going to manufacture CAR T from the same T cell of the patient. So the T cell also has some of the myeloid mutations, so which itself is a risk when you manipulate the same T cells. You go take it to the lab, manufacture, and then you're going to infuse in the patient. We don't know about the further leukemogenesis. So that is something to be noted with particularly CAR T cell therapy in autologous CAR T cell therapy in AML patients. So the best at this point of time where the field is moving is towards your allogenic NK CAR T cells, particularly in AML. And what are the various candidate target antigens? CD123, CD33, CLL1, CD7, CD70. So these are some of the targets that are being tried. So this is on the left, you can see the antigens, that is CD123, CD33, CLL1, CD7, and you can see the various percentages of expression. So you can see CD123 is the most common expressed, CD123 is the most commonly expressed antigen on your leukemic stem cell, followed by CD33, and CLL1 is kind of almost 78 to 92%. CD7 is lesser, and you also note that CD19 expression in core binding leukemias, that is your CBL AMLs. So you can see this CD19 expression as an aberrant expression in most of your CBF AMLs. So this is also exploited as a target that is a simple CD19 CAR can also be used in AML if they have an aberrant CD19 expression. So you can see these were some of the response rates. CD33 has got somewhere close to CR rate of 41.7%, but CRS also is literally manageable. It's not more than grade 2. CD123 CAR plus or minus dasatinib safety switch. That is, after some time, dasatinib is made to dasatinib is made to stop the expansion of CAR T. Right? This is again to switch off the toxicities. Right? And again, CLL1 CAR T, again, this was tried in multiple relapsed refractory AML patients. The only promising strategy is CD19 CAR, where you can see almost 60% attain MRD negative CR, 12-month OS and leukemia-free survival as close to 45% and 46%. Again, this was a paper that I pulled it from one of the Chinese papers. I don't know how to extrapolate it to our setting and how much it is realistic to practice in our country. Right. So again, as I said, since autologous T cells and NK cells have much difficulty in getting, and short sustaining efficacy and much on-target side effects, it's, nowadays the newer modality is to try off-target, that is, off-the-shelf CAR NK cells from a different allogenic donor and then use it for clinical practice. Right. So these were some of the breakthroughs of CAR T cell therapy in acute myeloid leukemia. This is the recent ASH update. So they keep trying newer antigen targets, like starting from CD64, CD45, 276, LAMP5, CLEC2A. Okay. And then the way that you engineer, the way that you transduce the cell is also, multiple types. And lastly, the manufacturing process. Some people are trying bispecific CARs. People are trying bone marrow, those CAR T expansion from those bone marrow cells culture for a prolonged culture, and people are trying using a different gamma delta T cell CAR. So these were some of the innovative targets that are being tried in acute myeloid leukemia, but still all the trials are in the preliminary phase. The efficacy is not much proved, right? So still it is not the standard of care as like your lymphoid malignancy. So I think there is a lot of work that needs to be done in this space. So with this, I close my talk and open for questions.
Thank you, Dr. Gopi, for covering everything in 20 minutes. As always, very clear, very crisp. Thank you so much. If anyone has any questions, we can ask. Our panelists, Dr. Akshay, anyone, or Dr. Sohini, anything, any comments?
So I think that was a very nice presentation, and we could learn a lot of new things. So this KMT2A rearrangement AML has always been a dreadful situation whenever we find in our patients. And it is good to know that there are so many drugs which are under development and they have proven to be very effective. The other question is about the quizartinib. So you told about quizartinib. How long was the maintenance? Was it the continuous maintenance or it was for a limited duration?
So I can see that it is for, they had continued it for 3 years.
They had continued for 3 years.
Yes, yeah. So that's what I could see. It was continued for 3 years. The main difference is
And
what I can find very striking in that paper is, irrespective of allogenic transplant, if they are put in at least for 1 year of
yes.
maintenance, they are remaining in remission with MRD negativity. So that is the main thing. On the other hand, if they on quizartinib, if they are MRD positive, they did much worse than the other, much worse than the control arm. So that was the another important fact that I found it from the paper also.
Yeah, because doing transplants in AML is always very, very difficult. The second thing was regarding the decitabine. So, what was the summary of the first thing? Is it the oral decitabine as equivalent as IV decitabine, and it can be used in the upfront setting?
Yes, the first study was the initial study as plain acetin AML study was just a pharmacokinetic study. Basically, they didn't aim at doing CR rates and all. So where they tried and proved that oral decitabine is equal to IV decitabine.
Okay.
I think once it comes, I think the AML induction will become more of an oral induction for AML. So it's like triple A for APML. It's like double DV or something for AML.
But that need to be compared with 3+7 then.
Needs to be compared with 3/7. I think most of us are now very comfortable using 7+7 or 7+14, I feel.
Yeah, great.
Yeah,
Thank
so
you.
I felt like among the updates, it's the menin inhibitors, those with the potential to improve our outcomes and survival, especially KMT2A and NUP98, and
Yeah.
NPM1 is still kind of manageable with
But I'm surprised why they are given such a poor OS rate for NPM1 mutated AML in the studies. In practicality, we somehow manage NPM1 mutated AMLs. KMT2A is really a nightmare, and it's a headache. Whatever you do, they kind of relapse. You transplant, they
they do
relapse.
poorly.
Revumenib is at least heard in the last year only,
Mm.
but I can see so much of work is going on with the other generation menin inhibitors, and I think with the newer agents like the Balom and then all these things, the response rates are quite high. It's almost they are given close to 80% in newly diagnosed AMLs.
There are two questions. One is from Dr. Gaurav Ujha. So, if a patient relapses post-transplant with KMT2A positive disease, is reinduction with a menin inhibitor feasible? And if so, how does prior exposure affect expectation?
Okay. So if the patient is not exposed to revumenib, then definitely your only choice is revumenib.
Hmm.
Revumenib plus HMA-vel.
Hmm.
Yeah, initial is if you use it as a single therapy, I think the response rates are only close to 20-25%. I think it's again a lost battle. But when you use it with HMA-vel, maybe you slightly get it higher by 36%. But if you use a newer agent, I think it almost doubles from 20, it becomes 40-46%.
Okay, another question is on role of CPX351.
Role of CPX351, at least I have not used up until now. So we are very happy and comfortable using our own naive agents. I mean, anybody has an experience, I think you can share, but I have not used CPX351 up until now.
Dr. Biswajit recently, he used in a patient. If he's there, he can. I'm not sure. I don't see him. But like when I was doing my fellowship in Vancouver, at that time it was the standard of care there for treatment related or MDS related AML, and the duration of cytopenias was quite longer than what we see with our 7+3. So. So there it was the standard of care. Here I have not used. It's quite expensive. Needs to be imported also.
So cytopenia, the duration of cytopenia, as you say, is the real toxic thing to manage here.
Yeah. Okay, we can move on to the panel discussion. There's another question. I think we'll cover it at the during the panel at the end of the panel discussion. Dr. Biswajit is not here. We can start. We'll ask him to join.
I'll be sharing the screen.
Ma'am, he will join me shortly.
Okay, sure.
Actually, he tried to join actually.
I'll just introduce I'll introduce our panelists. So I did not do that. Just give me a second. So for the panel discussion, sorry. So we have our moderator, who is Dr. Akshay Lahoti. He is an associate professor in Department of Clinical Hematology, MJ Medical College, Indore. We have with us also Dr. Biswajit Bhuiyan. He is also an assistant professor, Department of Hematology, KIMS, Bhubaneswar. Dr. Nakul, who is a consultant, Department of Hematology, Manipal Hospital, Goa. Dr. Sohini Chattopadhyay, who is an assistant professor, clinical hematology at AIIMS, Nagpur. Dr. Soudamini, who's an assistant professor, IMS in some hospital, Bhubaneswar, and Dr. S. Karthik, who's a consultant hemonc at Kaveri Hospital, Chennai. And myself, Dr. Satrupa. So we can start, sir.
Okay, fair enough. So is my screen visible?
Yeah.
Yeah.
So at the outset, thank you, Satrupa, for organizing this wonderful get-together, I should say, online with some knowledge sharing also. And we'll be talking, and it was a fantastic lecture from Dr. Gopi before this. And probably we will be discussing more of what we are doing together as clinicians with our patients in our respective hospitals. So we have fantastic panel today, and we have 7 leading hematologists from all over the country, and we all will be sharing our experiences, and probably this will be the reality sharing that what we are doing in our clinical practice. So we all will be learning from each other, and obviously the attendees who are there will learn a lot. So, before starting the question answer sessions, we'll just brief you and set the background that yes, the burden of disease in India's AML differs profoundly from the Western cohorts with respect to the age of presentation, their molecular profile, and the systemic barriers the patient face before they ever reach us. And when we talk about the epidemiology, so yes, we have a younger cohort of patient as compared to our Western cohorts. So the approximate age of diagnosis is 40 years as compared to 65 to 70 years. And this is very important because this is the population who is earning, who is the working age for their families. And there is a lot of diagnostic delays in all our patients because most of them come from the peripheral parts where they are being managed with the blood transfusions before coming and diagnosing with the disease. This biological heterogeneity is also very important when we compare because we have some limited data from our own country, but there is variation in the molecular mutations in the FLT3 or the NPM or the SEPA mutation rates as compared to the Western cohorts. And this algorithm is actually very important when we treat our patients because somewhere it is published that only 57% of the Indian AML patients have evaluable karyotype data at diagnosis, which is a critical gap in the prognostic accuracy. And unless we have our national standards that how many are suffering with the different molecular phenotype, probably we won't be able to do the upfront therapy, and probably we will be misclassifying and incorrectly prognosticate these groups. Again, there is an infrastructure gap. So we have diagnostic limitations, although with the advent of the national labs, probably we are all able to do the upfront diagnostic evaluation for most of our patients, but still for the peripheral parts, it is difficult because some of the diagnostic investigations are not available in house, and probably they are suffering with the transports also. So my first question will be directed to Dr. Karthik.
Yes,
Dr.
sir.
Karthik, are you there? Yes.
Yes, sir.
Fantastic. So, with the AML's molecular classification, which is rapidly evolving, what is the minimum diagnostic panel you do upfront for before starting the therapy? That is the first question. That what is the minimum molecular panel you would like to do in a newly diagnosed AML patient?
Okay. Sir, good evening, sir. Sir, so for molecular testing, for two things we have to do. One is for treatment director for getting the targetable mutations. Second one will be to assessing the risk stratification, whether the patient is in adverse risk or not. So at least I will go with minimum karyotyping. Second will be at least PCR based to check PML RARA, RUNX1, to check for the CBF 4 binding factor mutations, and FLT3, NPM1, and IDH1 will be my minimum molecular panel to check. So apart from this, if I suspect secondary AML or background of any MDS MPN, I will check for other myelodysplasia related genes.
Okay. So, with the cost of NGS coming down,
Yes, sir.
do you do NGS in all your patients?
So mostly, yes, sir. At least for elderly patients, I will go with NGS. If pediatric and adolescent, I will go with the minimum molecular panel PCR based.
Okay. So I recently had this 821 AML. So probably with so she was diagnosed as a standard risk. She was given 3+7 followed by 3 Hydax, and somehow she relapsed within 6 months of the treatment. So now when the NGS was done, it was c-KIT mutation.
Yes, sir.
So probably by doing NGS, we can pick up these high-risk patients earlier.
Yes,
While
yes.
not doing. So probably with the cost of the tests going down, we should do all the tests upfront.
NGS.
That is what I feel. so that we can pick up all these patients earlier and it is easier to prognosticate. Second question is, do you want to delay your induction or do you start immediately while waiting for your molecular test?
So most of the time, we get cases, at least some hyperleukocytosis will be there, at least some infection, or else TLS. So most of the time we tend to start treatment, but sometimes if the patient is stable, without any, with only mild cytopenias, no infection, no TLS, no hyperleukocytosis, we tend to wait. But it's very rare to see these kind of cases. So I tend to start treatment.
Okay, so it is 7+3 most of the time, or it is 7+14 as Dr. Gopi was telling?
Most of the time it will be 7+14.
7+14. So you agree with Azavan protocol as compared to 3+7?
Yes, sir.
Okay.
Based on
You're
the
practicing
recent.
in a private, because we have some limitation of time. I'll be rapidly asking the questions and they will be pinpoint. You are working in a government sector or a private sector?
So government, both I have worked. So recently, I worked in MMC, which is a government sector. So there, I tend to use 7+3. But in elderly borderline fitness, I move on to azacitidine when azaven protocol, sir.
Fantastic.
But private, definitely azaven will be my first choice, sir.
Okay. So do you find any patient who is non-affording for the molecular tests, and there will be many?
Yes,
so
sir.
what do you do?
So at least, as I said, sir, at least I will check cytogenetics will be the first choice, sir. At least I will do a karyotyping to check for any favorable cytogenetics transfer 821 inversion 16. So at least I will try to do PCR based FLIC3, NPM1 and IDH1, sir.
Okay.
So
Fair
nowadays
enough.
we have some genome giving some coupon codes only less than 5,000. So we used to do that for unaffordable patients, sir.
Yes, and probably we all are surprised whenever we know the actual rates of all the tests. Thank you, Dr. Karthik.
Thank you, sir.
So after the diagnostic, anybody wants to chip in?
Not now.
Hello. So
Okay.
can you hear me? Akshay.
Yes, sir. बोलिए.
Good evening. So means it's very paradoxical that one prefers 3+7 in the government setup. So government setup doesn't have
Sir,
any
I'll
ICU.
come with the specific questions about the treatment, and probably they are
Okay.
directed to you only.
Okay. Right.
So this is the initial diagnostic part, that what minimum investigations we all should do. Any comment on this, that in for all the patients, do we do all the things or do we stick to anything which is concise?
I do everything because NGS is now dropped down, and I push patients to do that because the rest is kind of covered by Ayushman Bharat, blah blah blah. So I try to get them to do that NGS myeloid panel. So that's one thing I really want.
With more and more NGS we do, I feel it's doctor protective because you will not be answerable for lapses. So I
No,
think
even with the cost reductions, most of the patients are actually able to afford it. And once they understand the implications of transplant versus non-transplant, most of them are quite interested. We are moving to a world of nuclear families. So upfront haplos could be to some extent cut down by that. So even in the poor socioeconomic status, they are actually going forward for the NGS.
And karyotype also, all the patients?
Absolutely.
Okay. So peripheral blood or the bone marrow?
I do a bone marrow.
bone marrow.
With the 80,000 WBC count and with 50% blast?
Still a bone marrow.
Yeah.
Bone marrow.
Okay. So we all are doing bone marrow for all our AML patients.
Yes.
Yes.
Okay. Coming on to the next part, which is the therapeutic challenge. So yes, from induction toxicity, as we all were discussing, that there is a lot of toxicity with 3+7, and there's a lot of financial burden too. And India's therapeutic landscape, it demands. So there is a huge gap between the axis and this thing. So there is comorbidity burden with the high prevalence of TB, malnutrition, other infections. We have ICU constraints in the public and the private hospitals. Plus, there is almost 20% of induction mortality, which is almost triple of the reported trials in the western part. So this is the problem with our nation, and this is the problem with our patients. So we need to design something which is applicable to our standards. So yes, and this is very much true that 80% of the cost is borne by our patient, and we all are surprised to know that almost 35% of the patients will not start treatment solely due to cost. So this is alarming. And when we are saying that 80% of the cost is borne by the patient and the family, and when we say it is the 40 years, which is the median age for our patient, so we can all understand that when the earning member of family suffers with this AML, who will bear the cost? So we all need to understand this part and how do we do that? So Dr. Biswaji, the question is directed to you,
Yeah.
that is 7 plus 3 for everyone who is fit, and is it still valid, or you are still individualizing induction based on genomics from day one of diagnosis? Sorry.
Yeah. So 7+3 is definitely still it is valid, but thing is that the most important thing are the finances actually. So we have 70 to 80% have got their cards like Ayushman cards and all those cards. So which has a limit of 5 lakhs. So means within 5 lakhs you have to give 3+7, manage complication, give 3 cycles of means HIDAC or IDAC, whatever. So it's almost impossible for means these kind of patients. And still we are suffering from the limitations of antibiotic means antifungals. So for these kind of patients, we are now giving Azaven. And if the patient is prepared, the patient is fit, and the patient has good amount of finances, like those 10 to 20% of the patient means cases. So we go for the 3+7 induction.
So probably fitness along with the financial fitness is very important to
Financial
start the 3
fitness is the
plus
most
7,
important. Yes, yes.
because our patients are bearing this money from their own pocket, and we don't have mediclaim for most of our patients.
Actually, our patients don't have money, so they don't pay from their pockets. So they pay from their cards. So once the card finishes, we are just left stranded.
Right. And this as a when is as smooth for you, or do you find any problems with the as a when protocol also in your fit
So
patients?
not really. So means it's a very means unpredictable kind of therapy, but it's quite. But I can tell it is safe. So sometimes with the 7 days means with as a plus when also the patient is having significant and prolonged cytopenias. So it depends. So it varies from patient to patient, but the acute incidence of means toxic deaths are less.
And how long are you giving venetoclax to your patients?
So depending upon the
7 days,
count,
14 days, 21, 20.
so we generally give around 14 days. But we see the counts, and if it is the depending upon the counts, so we taper it to 7 days for some patients also, and also the remission status also. Like we do a bone marrow, and if the means bone marrow is in remission, so means we can stop, and still the blast are there, so we continue till day 14.
Okay. So you are doing this marrow in the first cycle only?
Yes, so means after fast cycle we do, but in some patients like those suffering from significant cytopenias and 4 to 5 days with 4 to 5 days of ven, so we need to see the marrow. So means if blasts are there, then we try to continue means till the toxicity is acceptable.
Yeah. So sometimes there is a problem whenever we are having pancytopenia post induction of a treatment, and we don't know whether it is the disease or the drug induced. So that time we are supposed
Right.
to do it. Perfect. And do you feel that this venetoclax based induction can actually replace intensive chemotherapy?
Yes, yes. So means definitely in this group of patients. But thing is that not completely. So means eventually they have to be taken for transplant. So
But
depending upon the
actually, looking at
cytogenetic
the
group.
smile in
Uh,
everyone's face, you should understand that it has already replaced.
yeah, yeah. But so it's like
Yeah.
means it's like an open secret. So it's almost 70 to 80% of our patients are on Azaven. So 10 to 20% means I run 3+7. We also try to modify the 3+7 like 5+2 and all those things. But the toxicity remains the same.
Okay. The question here or the message here should be for the students that yes, Azaven is the most practical treatment what we are using, but it is not the standard of care. Again, the standard of care remains 3+7 for the fit AML patients. It is not Azaven. But considering our own circumstances and the patient's fitness, financial, social, moral, and all the fitness, we do take care that we are not able to go ahead with the most perfect treatment for our patients. So as a when probably is a compromise because we don't have any head-to-head trial which is saying that as a when is better than 3+7. Okay.
Ask everyone what dose of how long they're giving venetoclax. Favorite question.
Yeah.
What about
And
you?
so yes, 7 days to start with, and probably 14 days is my limitation. So in most of the patients, I'm not able to go beyond 14 days for whatever reason it is. And probably now with the venetoclax cost cut down. But somehow I have seen cytopenias most of the time with the 14 days of venetoclax also.
Yes. Yeah.
So favorable risk still you're doing HMA with na? Favorable risk also.
So now, Gopi, you are challenging all of us with the question which we do not want. So, favorable risk again, it is all depending on our financial fitness for most of our patients. So, whether it is favorable or intermediate or high risk, 3+7 remains the standard of care. That is the bottom line, I feel.
I mean, we could argue like adverse risk giving of like an adverse risk. There's an argument of favoring as a when and taking them to a transplant rather than exposing them.
Again, if patient is fit, 3+7 remains the standard of care because you want those patients to go into deeper remission upfront. Azaven will take a longer time, which is the argument against Azaven. So, although we have seen that 3+7 do not work as good as in the favorable risk, but yes, 3+7 still remains the treatment of choice in high risk also.
Exactly. All the more the reason is because all of the classifications of ELN even till date is only based on the intensive chemotherapies. It is not based on A7. A7 is a totally different classification if you see. So what you are calling as favorable risk core binding factor, even in with all the paradigm trial results, it is still 7-3 induction still stands good. And it will continue to stand good until we are able to find a better answer. But today it is 7-3 for now.
Yes. So practically, and what is ideally? So practically, we are discussing the practical aspects of India today, and probably Azaven is our favorite drug now. Now, as Dr. Gopi has already told us about the newer therapies. So this is about the emerging paradigms that with the newer mutations or many mutations what we are having in the AMLs, we have all the targeted treatment with the mutations. So for FLT3 inhibition, BCL2, IDH inhibitors, we have all those. And these are all now there with us. So Dr. Shoini ma'am, the question to you is, should every FLT3 mutated receive a FLT3 inhibitor in induction despite financial constraints? And we are talking practical situations. What are you doing? And what is the ethical framework when the answer is no?
So coming to how the FLT3, if we go back and see how the evolution of FLT3 has been over the last 10 years, FLT3 till 5 years ago or 6 years ago, till the previous ELN classification was there, it was bad. The only reason it came from bad to intermediate risk without even NPM1 was because there was a targeted molecule for that. And that's how the entire point of it becoming an intermediate risk has happened. Now, if we see in a resource constrained setting, the costs are exorbitant. If we are trying to give the patient midostaurin, the monthly expenditure is around 2 lakhs. If you're trying that's the generic. If you're trying to go and give the original molecule, it's going to cost more. And none of the trials actually have a limited duration of any of these molecules. We are using them till progression of disease. So, which is actually very much financially depleting for the patient. It causes a lot of problems. So yes, in an ideal world, we would love to give the patients FLT3 inhibitors along with their inductions of 7-3 or aza-ven. Although with aza-ven, the kind of cytopenia I'm going to get is huge with even these additional molecules. But I think bottom line that at least we are doing in our center is to take these patients through transplant. If we are having limited finances, we err on the side of saving the finances for transplant because that's the only thing which is actually going to make a big difference in the patient's life. And yes,
So
that's what we normally do.
out of 100 FLT3 positive patients, in how many are you able to give the FLT3 inhibitors upfront? Maybe just a percentage or a rough number.
So the number, I think around 10 to 15% of the patients that we come across have FLT3 ITD positivity. And amongst them, if you take it, maybe 20% of them are able to afford the generic midostaurin at least.
Okay,
But the rest
fantastic.
of them, who
And the
don't
problem
have,
with
it's there.
yes, and the problem with Ayushman in our MP is probably this aza-ven is not covered under any
Exactly.
Ayushman schemes for us. Is it covered in any of the states?
Yes, yes.
aza-ven?
So, as I said, in venetoclax covered in means our state, Odisha. So it's
Okay.
there. So it's there.
Gopi, Nakul?
Triplocoline is there.
So practically, I have no idea on this government scheme.
Only ASA is covered.
ASA is
When
covered,
is
sir.
not. Only
When
ASA is
not
covered.
covered.
When is not being covered. But I think with the new generic which is getting launched, we might have different answers coming.
So
Yeah,
we
same
have
in Goa.
when
Yeah.
covered. So it's around 1 lakh per cycle, I
Yeah,
think.
in Odisha, actually, it's being covered through the PMJ, Ayushman.
Yes.
Okay.
Nakul was telling something.
Nakul is also telling that yes, it
Yeah,
is
yeah.
covered.
So Ayushman is not there in Goa. There is a
Mhm.
separate scheme. Here it's only as a cited in. We tell them to buy the venetoclax.
Yes.
Yeah, in for this like midostaurin is not covered. And midostaurin I haven't. It's not covered under
It
Ayushman
is
Bharat,
not
but
covered.
Not
yeah.
no
It is
no.
not covered. None
So
of the
none of
newer
the targeted
molecules.
agents are there.
Sorafenib I think is there for us.
Sorafenib is there, but it doesn't really, PMJ covers for sorafenib. So there's no real data to say that
Yeah.
sorafenib works upfront. It is all about in post-transplant maintenance. So that is my go-to molecule when FLT3 ITD happens, take them through transplant because sorafenib is really cheap.
Yes,
It's
that's what
8,000
we are
or 9,000
using.
rupees per month.
Yeah,
So
exactly.
that's what we give our patients post-transplant. But as I said, if
Okay.
limited finances, transplant is the first thing and not the higher end molecules for us.
Okay. So I'd like to ask Dr. Satrupa and the organizers, it is already 7:30. How long we can go ahead?
I think if the panelists have time, we'll continue.
Yeah, please continue. So
Yeah.
means
Yeah, it's a
interesting discussion.
very interesting
Yes,
discussion.
exactly.
Uh,
Subhashri, are
I
we
would
good to
just like to
continue?
interfere here. Just one question. When you say generic midostaurin, which are the normal generics which you will use? Means of which companies?
I have used Intas and Dr.
Yeah.
Reddy's.
Intas and Dr. Reddy's is what I also use.
Fine.
Yeah,
Okay.
Intas and
Okay.
Dr. Reddy's.
Thanks.
I have used sorafenib upfront.
Any answer from the organizers?
I have asked her. We can continue till she answers.
Yeah. So we'll be more quicker now. So, ma'am, the ethical question is here that when we are not able to give the targeted agents to our patients because of the affordability, so how do you counsel that those patients that probably this drug is available and probably you won't be able to afford it, or you don't tell them at all?
So as Satrupa mentioned, that's exactly what I do in my practices. We don't add in any of these agents upfront. And we take them through a transplant and give sorafenib maintenance. So sorafenib works very well in FLT3 ITD. There's no data in TKD, and it's not required also. But sorafenib in very low doses, something like 50 mg, actually makes a lot of difference to the patients. So it's a cheaper alternative.
Okay, the toxicity is a problem, although with the sorafenib. You are using it,
Yes.
sorafenib?
Yes, I have been using it for quite some time. We start with something like 50. We ramp up the dose. You start with 50 and you go slowly up. Most of the patients start having toxicity at doses of more than 200. So 50 to 100 actually makes a lot of difference to these patients.
Yes, even like we have combined for some patients, in IDAX for 7 days. I mean, I can't really say that there is some, like I can't quote trials. It's just, something that we have to do because we have all of these problems with accessibility to drugs.
Okay, so sorafenib is a new learning, and probably we have all been thoughtful that probably it is more toxic. We had been using this midostaurin only, but probably with your advice, we will be using this
Yeah,
sorafenib now.
start with 50 or
Yeah,
something.
50, small
Yeah.
dose.
Yeah.
The learning would that we have come across as in only as maintenance, because the toxicities definitely ramp up in the inductions when you're already having other kinds of problems coming in.
Yes. So Nakul sir, your question. Is MRD truly changing treatment decisions in your practice, or does it remain largely a research tool in the Indian context? So when are you doing the MRD for what, which patients? So probably with the Azavan, when are you doing? With the 3+7, when are you doing? And how do you guide your decisions?
So, coming to your first question, I hardly do MRD mainly because of the cost constraints and standardization issues with the lab. I have my doubts about them. Secondly, when I'm going for 7-3 flag when or those intensive chemotherapy regimens, uh, CR, morphological CR is what I will target for. As a when they are beyond 9-10 cycles that and the patient is going good, that is when those small questions come up. Shall I stop the treatment, or should I continue? That is when there are off the label. I just try to do an MRD, see whether they work or no, and try to put them on wean off the therapies. And with regards to what you say, the transplant part, that's not the decision making tool for me. Morphological CR, go ahead with transplant if at all we are going for the MRD.
Okay. Anybody? Dr. Gopi Satrupa, madam.
Intensive induction, there is no doubt that we'll do it at the end of intensive induction and then decide for consolidation versus transplant and so on. But particularly with the doubt arises mainly when with azacitidine and venetoclax, and particularly in a transplant ineligible candidate when to do MRT, right? So I follow this approach. So suppose if they are up until day 28, if they are recovered counts, actually I don't do cycle 1 MRD. I actually shifted to cycle 2 because we very well know that with very good count recovery and the MRD negativity also increases over the cycles. The patient may be MRD positive at first cycle, but they can become MRD negative from cycle 2, 3, 4. So I don't do MRD. If at all the count recovery is good, I don't do MRD at cycle 1. I try to keep it at cycle 2. And anyways, because you're not going to change the treatment unless there's a frank relapse or frank this thing, you're not going to change the treatment. So that is for those patients who are recovering counts. But definitely somebody was not recovered count, say for example, at the end of cycle 1, if they have some kind of cytopenia, that time I just do a marrow to confirm whether it is hypocellular or there is frank disease. And luckily, in most of the situations that I have to do, it was only hypocellular. Hardly I had encountered the persistent disease and all this stuff. So that is how I sequence MRD in HMA when backbone. And once after I do cycle 1 and I document cycle 2 and I document remission, then as Nakul was bringing out this point, how frequently do you repeat MRD, particularly in the context of Azavan therapies? So at the end of 1 year of Azavan regimen, I do an MRD just to see if the things are still going good or if there is some kind of altered regimen. But towards the end of second year and third year, patients really get exhausted more than the first year. So that time I actually try and do a NGS MRD. So this is the approach that I have developed. That's it. So it is not evidence proven, it is not evidence based, but this is something, I think the landscape is still evolving. There are no straight answers to this. So this is what I do.
For the MRD positive patients, so is it the morphological remission or the MRD positivity which decides you to go ahead with the transplant? So does the MRD affect your transplant decision?
This I'm talking about in all those transplant ineligible candidates.
For the transplant eligible patients.
Transplant eligible candidates, yes. Obviously, I mean, anybody up until 60, 63, we are offering transplant.
So if the patient is MRD positive post consolidation, do you take him for the transplant or do you want to do the MRD negativity before transplant?
Okay. Again, I would, in that case, see, in ALL, definitely yes. But if in AML, if the patient's fitness is really not kind of a tricky or borderline, then I would not try and induce him, make him slightly unfit, and then take him. That becomes a complicated call, I should say. So I'll directly take them up for transplant. Again, highly patient dependent. Because
Highly patient dependent. And if we have some therapy, if the patient is fit, probably we want to do it MRD negativity by some of the therapy.
Yes. That is definitely there. But if somebody, say for example, 60, 61 years, 62 years old, I really there don't try and push in for, because getting him a transplant itself is a big task.
Fair enough.
What happens when you're dealing with a transplant eligible person? Because the most common places where we are actually forced to use azaven is in infected patients. Because in India, we don't get clean patients of AML. They come with an infection. And we start off with azaven, treat the infection, treat the pneumonia. The paradigm happens when the first month gets over, counts have recovered, and now you're not sure which way to go. So do you use MRD to guide treatment to change over to intensive, or do you use
So in that
MRD to be on the same page?
In this specific context of patient that which are talking, Sony, anyways, after an azaven, I would shift to intensive induction once. Then I get an MRD, then take a decision to do transplant. Where in this subset of patients, I know 3-7 is a standard of care. But if I decided that I need to proceed for transplant, I kind of do an induction like flag vein or flag ADA regimen, and then subsequently take them up for transplant. So that has been my approach.
And the problem with the elderly patient is that probably we won't be able to give the intensive induction. The second problem is whenever we are taking them for the transplant, we won't be able to do the myeloablation. So probably we will be doing the rig conditioning for most of our patients. And with the MRD positivity rate, probably it is wiser. I'm not sure whether it is wise or not, but probably I'll try to defer the transplant as long as possible, because I know that the patient will relapse post transplant. So why to do all those things? And if the patient is very adamant, then probably we will take him for transplant. So it is all the verbal communication what we want from the patient.
As highlighted, there was a discussion in the last MHG meeting about, as Dr. Gopi said, of taking an MRD positive AML patient to transplant versus, waiting, giving them another cycle and then, causing more toxicity and taking them. So, and the consent, the discussion was centered around, it's better to not wait and, take them up for transplant and use a myeloablative conditioning if you can, but then that's again something difficult in our setup, and proceed. So
first of all, we all should do MRD. That is the primary thing.
So what I understood from all of this is mainly we to decide on transplant we are using MRD, right? So that's our main goal.
The second goal is with the azaven therapy. Probably when you want to cut down after 6 cycles or 12 cycles, if you want to cut down, it is not very evidence proof, but somewhere we tend to do that. So probably we will delay the cycles by 45 days or something. Or probably we need to cut down on the venetoclax after we are having the MRD negative value. So I do that in my clinical practice. After 6 cycles, I do the MRD. And if it is okay, then probably I shift it to 30, 40 days per cycle.
What about the second question in the slide, favorable risk post consolidation MRD positive? How you'll approach? Monitoring closely? I monitor closely, but what do others suggest?
Transplant if you can.
So for the 16 and for the NPM1, we have these ddPCR guided MRD. So we need to follow that. If there is a 2 log increase in the MRD log, probably you will tend to do some treatment for those patients.
Okay.
So, Dr. Gopi.
Yeah, okay.
So, which AML should definitely undergo allogenic transplant in first CR, and which patients can safely defer with your azaven therapy?
Okay. This is with azaven therapy. Okay.
So, because we are giving azaven for our patients, no?
Yeah. So, anyways, in intermediate and adverse risk, transplant is the first word that I would utter because that is the proven strategy for long-term disease control, bearing the TRM and so other things. That's a proven therapy because again, if they relapse, getting them to a second remission doing a transplant becomes a complex job. So the straightforward answer is for intermediate and adverse risk definitely is, and definitely all the more if they are MRD positive, all the more is. Again, the strategy to get them into remission is a bit different between each of the patients. And then biology versus financial toxicity. Definitely, this is an important question, but I would give more. I mean, I would say 50-50% weightage to biology and financial. It's a very difficult question to answer. I mean, though it's textbook answer, we can answer fast, but this is a very practically this is a very difficult because again, you do a transplant and then you ask them to the main cost I feel the main challenge that I feel can do a transplant, but post transplant the family should still be motivated to get chimerism, MRD every 3 monthly. So that is a main challenge. So patients have a mindset that transplant is done, kar diya to kar diya, bas that is their mindset. But again, a whole lot of things happen after transplant. What if the chimerism drops at 6 months? What if the chimerism drops at 7 months? What if you have an MRD positive? So I think that we should have a fine, delicate balance set. And what I am just following in the current subset of patients is most of these patients, somehow I see, particularly when transplanted for a high risk AML, they all do drop. I mean, they are somehow at some point of time, we do have some mild MRD positive clone coming up. So there is data from this maintenance strategy. So as early as 3 months to 6 months, the counts are all okay, not much of GVHD. You can just keep them on prophylactic ASA maintenance, somewhere between 3 to 5 days of ASA maintenance. So that is something that we can do. The last question has the growing availability of haploidentical transplantation change your threshold for recommending transplant, expanding the eligible pool. So the highest age of PTCY, I think what I had done is at 63. So nowadays, I think we have a strong data about reduced dose PTCY, correct? I think 35 mg per kg is what most of the centers are following. Given a context where I have to choose between haplo versus mud, sometimes I feel mud is a real problematic situation. You may have to wait. And what if something happens post transplant? If your chimerism drops, all this stuff, you may have to. That's a real challenge. And I have been faced with the same situation at least twice or thrice. So now I think if we see the survival curves also, I don't think there is much difference between mud versus haplo in our Indian setting, at least with the PTCY backbone. So I think now my preference is more to go for an haplo, provided the patient fitness after clearing all the pre-transplant workups or all these things are done. You can go for haplo. With increasing age, I think you can come down on a bit of PTC by 35. I know the paper from the seminal paper, which used to be shared from the Princess Margaret Center, has low dose ATG. But in practicality, you don't even need to do that low dose ATG. You can just get away done with 35 mg per kg of PTC.
Fair enough. So at what point you are doing this? So probably you have given as a win to your favorable risk AML, and now he is MRD positive after your 2 cycles of Azaven. What do you do then?
Is that favorable risk AML? I believe that the age is also going to be slightly lesser. So in this patient, I would just do an intensive induction, get them MRD negative and take for transplant.
Fair enough.
Say, for example, if some adverse risk or something like an intermediate risk AML, where if the fitness is borderline, if they the answer remains the same, if they're borderline fit, then I would just directly move them to transplant and kind of start strengthening the post-transplant strategies.
Yes, and doing haploidentical transplant, if the patient is undergoing an haplotransplant, probably with 30-35 lakhs of money, then we are supposed to take care of everything then, the NGS MRD, the flow MRD.
There is a catch there. So we have this government scheme approved at our center. So the government supports for transplant, but the post-transplant maintenance is at stake. So patient do spend some amount of finances in the pre-transplant time. I mean that the induction time, where at least a minimum amount of money is spent. And the post-transplant time, again, have to keep doing marrows, you have to keep checking chimerisms, even CMV checks everything. So that is a challenge. So not that all come with a ready-made cash of 30 to 40 L in their packet and then they come, but there are some patients whom we have to really navigate. And every time, even they come with some 5 to 6 episodes of loose rolls also, you have to think whether to get a scopy done or you just add directly steroids. You do think each time.
Yes, it is actually very difficult and challenging. It is very difficult. And when the haplotransplants complicate, it is actually the hell of a situation. So I had two patients who had all these hemorrhagic cystitis, and for 2 months I was managing those things. So it was actually very difficult. And after that, probably my what love for haplotransplants had gone down. Well, it was an acute onset gone love. So the role of stem cell transplant we all know, and yes. So the next question is for Dr. Sudhamini. She has been quiet for a very long time.
No, I
Are
was
you
listening to the entire discussion actually.
okay? So, ma'am, for you, the question is what defines fitness in a 65, 75-year-old Indian AML patient? Is it the chronological age or a biological age? Because we know in Indian population, probably we have more of comorbidity burden as compared to the Western parts. So, at what point do you consider them as fit, and at what point you consider them as unfit?
Yeah, actually, for the Indian setup, I think it's the biological age which is more important, because for starting the induction therapy, we all know that the AML patient, they won't be fit like all the other patients. Everyone will be coming with a very bad pneumonia or something like that. So while considering for the chemotherapy, I'll definitely look for the frailty index, the performance status, the organ specific, any toxicity is there or comorbidity is there or not, and like any other comorbidities, that part, and also the financial burden and the emotional quotient of the patient.
Right. Are you following any tools to assess the biological age or the
Not
fitness?
exactly, you can say, fitness, I'm using the clinical frailty score actually.
Okay. So that is giving you some outcomes that whether you need to go for the intensive induction or the SRN somewhere.
Definitely. Actually, those patients who are maybe at the age of like 40, 42 young adults, yeah, but they have with a very frail, they are very frail and with a lots of infection, very bad pneumonia. For them, I'm not going to start 7+3 at the induction point. I'll initially start with the azaven, and once the patient is being stable, in the meanwhile, I'll also get the NGS or the cytogenetic and everything. Then accordingly, I can decide whether in the next cycle I'll go for the 7+3 or what next I have to do.
Perfect. So anybody who is following any geriatric assessment in the clinical practice, or it is all the clinical acumen what we apply?
So yeah, the clinical assessment is means even more important for us, especially
Yes.
than
So
those full
basically we are
scoring.
taking care of everything. Yes. Okay. So the very important part in our AML patients is the infection control and the supportive care, and which we want to be done as a team. Obviously, we do struggle whenever we are practicing individually to take care of all these infection and the supportive care practices, to take care of all the nurses, to take care of all the staff, to teach the patient's family repeatedly, and following the hospital's protocol is actually difficult. So our program director, Dr. Sadrupa, the last question is directed to you that what remains the single biggest barrier to successful AML treatment in India? Is it the infections, product availability, or delayed diagnosis? And what are you doing at your institution to control or take care of all these supportive care in the infection practices? Are you teaching them? Are you doing any audits? Well, that is what I want to understand. How do you do that?
Yeah, so for me, infection is the biggest challenge, and I think one, infection; two, delayed diagnosis, and third is blood product, and fourth will be drug access, if I put it that way. And for our inductions, I try to use a PIC line for the patients, and for that, our nurses are regularly being trained. We take classes. We ask the PIC line, the BD and different people to come and teach them. Like multiple times, we are trying to teach them about care and maintenance of a PIC line, use of hand hygiene. And so we have a good IPC team, like the infection our microbiology team. So they come, they survey. So they're very vigilant on CLAPSIs and all. So that's the part that you can control to some extent. I think the rest is quite difficult to control. And like fungal infection, so we give routine post my go-to is posaconazole prophylaxis with venetoclax, and even when the patient is neutropenic, when once you're giving 7+3. And besides, no routine antibacterial prophylaxis. Whenever they are neutropenic, we can do whatever. And another thing is, giving early antibiotics. That's something we have, tried to, emphasize. 1 hour, within 1 hour, when the patient's counts is low, try to give them. I think it's just we put standing orders, we write standing orders, we emphasize everything. So that so somehow, it's just trying till our infection rate comes down.
Probably we need a team. We need to teach our doctors, our staff, that they should remain with us throughout our life, and we do not want them to go away once they are learned. So that is something
And we
that,
can also make some actually neutropenic rooms, like the same with the same general ward charges, like 6 to 8 neutropenics to room for this AML and aplastic anemia patients
Dr.
with the
Biswajit, that
same
can
charges.
happen only at your private medical college. Our corporate hospital will never ever get us that.
So 100 rupees per day you can charge and you can make that room.
Either corporate will give you, nor a government hospital will give you that. Because in corporate it'll be financial toxicity, and in government setup it will be an open board, space constraints.
Financial toxicity is to the doctor. If the patient doesn't pay bill, they come and sit on.
Both
Yes.
ways.
anybody who is having a mobile staff who is doing all these PIC line dressings at home.
Actually, in between, this BART guys came up with a program where they, I think you pay a nominal charge of some 500 rupees or 1,000 rupees. They had a national toll-free number, but somehow I think the program didn't take off well. So I was using it for a short while, I think 6 months to a year. But I think probably the program didn't take well. Probably not many of the colleagues did put PIC line, and they weren't calling them for help. So I think the program didn't sustain. But given a chance, I think if we propose them, I think they'll bring back the program back. So they
Right.
charge very nominally, somewhere between 500 to 1,000 rupees, and they go to the home and do dressings.
Yes.
Okay.
Because getting a PIC line and then getting it infected
Oh.
and getting it removed because of that is actually we do not want. So, right?
Actually, I would like to ask one question for the PIC specifically. In like if the culture is positive for the PIC line and for the peripheral line, are you going to remove it? Or in a specific infection only you want to remove it, or any chance you are using antibiotic lock therapy?
Infected, remove. My principle.
Any infection.
So if you are, the question is if you're getting it from the peripheral line as well as central line, correct?
No, I'm asking it's like if the patient is having Klebsiella MRSA staph infection is there, definitely it's going to be removed by any means, because the PIC line itself is very costly and every things. So if by any chance you guys are using antibiotic lock therapy, or you're straight away removing the PIC line?
Actually, since you said that it also grows from the peripheral line, if it is an MDR bug and gram positive, definitely removal. Otherwise, you try and salvage the PIC line. You
Yeah.
do some antibiotic lock and try and salvage the PIC line, because again, getting it if it is a sensitive bug and if you're able to try and get a lock, then again you can still
Yes.
we'll salvage some lines to that
Actually, in one of my ALL patients, not in this context, in ALL patient, it was, I think, some other patient, not Klebsiella, MDRO and staff. So I have used an antibiotic lock therapy. And after giving a challenge for 7 days, again, I repeated the culture. This time it came out to be negative. So I again reused the PIC line.
And there is no standardization on the antibiotic lock. I don't know what, I don't know, I never found it. And some centers don't even, there's no validated data, I think. So I think to each is his own kind of. But I agree with
Yeah,
Dr.
actually,
Gopi.
there was no.
Was
Yeah.
there growth in both peripheral and central line, Dr. Saudamini?
Yes, ma'am. Yeah, ma'am, there was a growth in both PIC line and matlab in the PIC line also and in the peripheral line also. There was a sensitive to sensitive antibiotic was there, TG cycline. I have given a TG cycline along with that and the antibiotic also. Why using for 5 to 7 days, I have not given a PIC line. Only antibiotic lock has been given and it was there. Once after 7 days, when I repeated culture, it came out to be negative both in the peripheral and in the PIC line. Then I have restarted it actually.
Right. So PIC line management and maintenance is a problem what we all face. And that is why sometimes we tend to avoid putting a PIC line when we know that the patient is living far from our hospital. So yes, this probably is the closing statement from our whole panel that the quality of life is as important as metric as overall survival, and in our Indian AML populations who are particularly older or those with high financial burden, and so probably chronic transfusion or giving as a when probably as the only palliative treatment as of now, if we are not planning any transplant, stands a positive value for the family and the patient if he can live for another 2 3 years without, so probably independent. So that is what it is, and we need to vision 2030 with Dr. Gopi's lecture that we have so many drugs coming, and probably in all the patients wherever we can use those drugs we should use, because AML is dreadful disease and we need a lot of curative therapy for these patients. So with that, I would like to thank you for the wonderful panel and the IAIO and Dr. Satrupa for organizing this wonderful webinar.
Thank you, Dr. Akshay. And I apologize to our attendees for overshooting our time, but it was so interesting and to learn from each of you as to what we are doing, because all of us are doing it a little differently. So thank you so much to both the panelists, the speaker, Dr. Gopi, and to our attendees. So we don't have time for question answers. So next time I'll keep that in mind to have a longer panel discussion, considering it's so interesting.
I think
So
You
next
can
time
just
you can
answer
start
the
with the
chat
topic.
questions if the organizers allow. You can just answer them precisely. I think there are not many, if at all.
Yes,
So I
Sapna.
think before that, I think Akshay had presented a SIOP paper in first year DM in our seminar. So
Yes.
all these things have become even means Wayne was not available. Hello.
okay, yes.
So means Akshay is there.
I'm here and I have forgotten
हाँ
that paper.
मैं तो नहीं प्रेजेंट किया था एक साहब का पेपर
Ah,
that the AML patients in a means resource constrained setting. So means
oh
they
yes.
had advised for a pre-phase of steroid, 6 MP,
Yes.
and means oral etoposide for 14 days. After that, the patient is fit. You can give a low dose of induction therapy, and all those things have become actually means obsolete and outdated
Yeah.
with the
Yes. Yes.
venetoclax.
Yes. Very true.
Okay, so there's a question, just brief one, two. In FLT3 TKD, can we use sunitinib? I don't know. I don't think I have no, there's no data. So post-induction CR, but MRD positive. Should we do allo transplant? Which condition regimen and why? This either you or anyone, like, or Dr. Gopi or you, Dr. Akshay.
Can you repeat the question?
Post-induction CR, but MRD positive. So should we do
Uh-huh.
allotransplant? If yes, which conditioning regimen?
So again, as we were discussing during the panel also, and Dr. Gopi has quite highlighted that. So if you have MRD positivity, probably you want to give one more induction or consolidation if the patient is fit to make it MRD negative. If you don't have that provision, probably a flu-bu4 or yes, myeloablative conditioning is what is recommended in patients who are MRD positive post-induction.
Okay, so I think we should wind up now. Again, a very it was really interesting, and thank you so much, everyone. And I hope I hope to see you in more discussions like this. And yeah, so thank you.
Thank you.
Thank you, ma'am. Thank you. As we come to the end of today's session, I sincerely thank our program director and distinguished faculty members, panelists, and delegates and participants for making this session highly interactive and academically enriching. On behalf of IAIO, thank you all for your available time and participation. We look forward to welcome you to our upcoming IAIO academic programs. Have a wonderful evening. Thank you, everyone. Stay safe and take care.
Thank you.
Thank you,
Okay.
ma'am.
Bye,
Thank you so
bye,
much.
bye, bye.
Bye. Good night.
Good night.